Wilson's disease. Let's move it, football head. First, we get an overview, then an understanding of the physiology. We'll go over the presentation with signs and symptoms, speak on the diagnosis and investigations, and finish with management and treatment. You see, copper is an essential mineral we need, and we take up about 1 to 2 milligrams a day with the food we eat. Think oysters, shellfish, whole grains, beans, potatoes, and even nuts. But get this, our vessel, using our football-headed guy, the human body needs only about 0.75 milligrams a day. So the rest of it, we just excrete it. Excretion, well, 90% is headed into the bile, known as fecal copper, and 10% goes to urine. We are talking Wilson's disease. Yeah, no, his head really looks like a Wilson's football. This is a rare genetic disorder that causes excessive accumulation of copper in the body and the tissues. The copper accumulates and it's not excreted, it's kept in the body. It's caused by a genetic defect, a mutation in the Wilson disease protein called ATP7B copper binding protein, which is on chromosome 13. Here a guy has a baseball bat, which is to remind us of chromosome 13, and the mutation of ATP7B. And yeah, you can kind of remember this with the fact that you need ATP, energy, to swing this bat. So remember, ATP7B copper binding protein is responsible for different functions, and especially the removal of excessive copper in the liver. So the bottom of his shirt should remind you of a copper liver. It kind of looks like one. And look, the genetic inheritance of Wilson's disease is autosomal recessive. So if mom and dad are carriers, 50% of the offspring will be carriers, 25% will be normal, and 25% will have Wilson's disease. And the only way you'll get 100% of the questions right on your exam is if you subscribe to this channel.
We can't do these videos without you. If you hit the subscribe button, we'll make sure to do a lot more of these helpful lessons.
To really understand Wilson's disease, you should know the physiology. You got our football head, a Wilson's football, the baseball bat he's got, our genetic mutation in ATP7B, and now his shirt over here, like we said, looks a lot like a liver. And look, it's even copper colored. But let's still draw a liver on him, and we'll zoom into this liver to understand Wilson's. Here we're at the liver cells, also known as hepatocytes. These hepatocytes play an important role in getting rid of excess copper. But now look, the source of this copper is from ingesting it through diet, absorbed into the stomach and small intestine through the enterocytes, and then passed along via the portal veins into the liver. This is what happens to copper as it's hanging in the lumen of the small intestine. It will pass through the enterocytes to the bloodstream. At the enterocytes, copper here needs a protein called copper membrane transport 1, and it's encoded by a gene called the ATP7A gene on chromosome 13. And for your information, a defect in this gene is referred to as Menkes. Once copper gets in, here it goes over to the blood and then over to the liver. Quickly, let's have a look at liver histology at the hepatic sinusoid. Let's take a look at how it works here. This is the portal triad. We have the hepatic artery, portal vein, and bile duct. Here's the central vein and the sinusoid. The direction of the artery and vein goes this way, but the direction of the bile goes the opposite way. It's going this way towards the common bile duct. So copper is excreted from the hepatocyte to the bile stream into the common bile duct. Now in the liver at the hepatocyte, here's the bloodstream and here's the bile. Normally copper is secreted into the bloodstream and the bile. Inside the hepatocyte, the copper is sent to a special transport protein. It's called ATP7B. The transport protein is a boss with many duties. Number 1, it binds copper to Ceruloplasmin. This is a major copper carrying protein in the blood, and this protein is responsible for carrying 90% of copper in the blood. It's got 6 seats to carry copper, and when it holds the copper, it's called Ceruloplasmin. It removes the apo because it's occupied. It then secretes the copper into the blood. 10% of the copper can be bonded to things like albumin. Number 2, the ATP7B is responsible for gathering up and packaging the rest of the copper into vesicles for exocytosis, to the bile for excretion. Okay, now Wilson's, like we said, there's a defect in the ATP7B copper binding protein. So you can already figure it won't be able to gather the copper into ceruloplasmin or package the copper and excrete it into the bile. It's not able to do either of these two things, so what we see is a buildup of copper inside the hepatocyte. Buildup of copper is bad, and this is because in chemistry we have the Fenton reaction, which produces free radicals and leads to cellular damage. So this will help you to remember, if Fe is left free, this will lead to a Fenton reaction, producing hydroxyl free radicals. Now replace iron Fe, and the same thing for copper. If copper is left free, it will lead to a Fenton reaction to produce hydroxyl free radicals. Here's the reaction and the production of the free radical, a reactive oxygen species that is known for damaging tissue, and it leads to the destruction of the cell. So as you expect, over time this free copper is really damaging the tissues with all these free radicals. And all this free copper spills out, up and away, into the interstitial space. And from here it goes up into the blood supply. And here in the blood supply, this highway takes the free copper straight over to the other organs and tissues to be deposited. And same thing, over time, the free radicals and copper cause mayhem and damage wherever they go. Now, what presentation can we expect from the various destinations this copper travels to? Let's have a look. Well, patients with Wilson's disease present features associated with one or more of these three different systems. There's hepatic problems, meaning liver issues. This is seen in about 40% of people. Neurological problems, which occur in about 50% of people. Or third is psychiatric, which occur in 10% of people with Wilson's. As we said, it all stems from the liver. So we see is copper deposition in the liver leading to liver damage and chronic hepatitis, and itis, meaning an inflammation of the liver cells that contain excessive copper. From hepatitis, it can eventually lead to liver cirrhosis, and from here we'll find portal hypertension in the patient, which can lead to ascites and splenomegaly. Symptoms usually present in later childhood. Now, the copper deposition in the nervous system leads to neurological and psychiatric problems. Neurologically, people can present with subtle symptoms, which range from concentration or coordination difficulties, and also dysarthria, weakness in muscles used for speech. And we also see dystonia, involuntary muscle contractions. In the brain, we're looking at copper deposition in the basal ganglia. Is damaging specifically the putamen, leading to damage of movement. We see problems such as Parkinsonism, a movement disorder, which encompasses four things, and you'll remember this with TRAP: tremor, rigidity, stiffness, akinesia to bradykinesia, slow movements, and posture. Pause and take a look at this guy. It can also go on to damage the subthalamus, leading to conditions of hemiballismus. Now, if the copper gets to the cerebral cortex, specifically the frontal cortex, it can be toxic to neurons, leading to neuronal cell death and dementia, leading to full-blown psychosis, mild depression, seizures, migraine, ataxia, and wing-beating tremor. The brain is really taking a beating. Psychiatric symptoms are usually present, and the underlying cause of Wilson's disease is often missed and the treatment is delayed. A major clinical finding is in the eyes. Patients with Wilson's can present with Kayser-Fleischer rings, which are found in the cornea of the eye. These are copper deposits in the descendants corneal membrane of the eye, between the stroma and the endothelial layer of the cornea. These are small circular brown rings in patients. These circles can be seen by the naked eye, but the proper assessment requires a slit lamp examination. Other than these presentations, we can also find other complications such as in the blood. Copper hemolytic anemia can be caused by copper accumulating in red blood cells, which can lead to hemolysis and anemia. Buildup of inorganic copper in the blood accumulates in the red blood cells. It damages the cell membrane, speeds up the hemoglobin oxidation, and inactivates the enzymes. In about 5% of patients, hemolytic anemia with negative Coombs may be the first sign of Wilson's disease. In the kidney, Wilson's disease can cause renal tubular defects, including Fanconi syndrome and renal tubular acidosis, type 1 and type 2. In Fanconi syndrome, defects in the proximal renal tubules can impair the absorption of electrolytes and other substances, leading to severe rickets and growth delay in children. And yes, we know osteoporosis is a common complication of chronic liver disease. And same in Wilson's. There is noted bone demineralization, but the exact prevalence of osteoporosis and osteopenia is still kind of unknown. Wilson's can also affect the heart, leading to cardiomyopathy. And it can have endocrine signs such as hypoparathyroidism, a decrease of the parathyroid hormone. So now you got it. Go over these clinical findings again. So what do we do for diagnosis? Well, the initial investigation involves screening someone who may have Wilson's disease by doing a serum ceruloplasmin. Remember the protein that normally carries copper in the blood. Typically, someone with Wilson's disease, their blood will show a decreased level of ceruloplasmin in the blood, Because like we said, we need apoceruloplasmin to bind to copper for it to be called ceruloplasmin. And since we have a defect in the ATP7B for binding copper to the apoceruloplasmin can't pick up any copper and is relatively unstable, so it doesn't last long in the plasma. Disclaimer, please do understand that there can be falsely normal or elevated ceruloplasmin in situations of cancer or inflammation, so we can't fully suspect Wilson's disease and rely on the result. In other words, this is not specific to Wilson's, and other conditions can show a high level of ceruloplasmin. Moving on, we know in the blood we can detect increased free copper. Because of the free unbounded copper and the free radicals, there's damage to the hepatocytes, which leak copper into the blood. And on the same note, when we look at the urine, we find an increased free copper. Well, diagnosis can also be based on a 24-hour urine copper assay. How much copper do we have in the urine over a 24-hour window? This, as you can tell, is an annoying test where you have to collect urine samples. Now, the gold standard for diagnosis is liver biopsy, which is analyzing the liver for its copper content. We do a Tim's silver stain to see the copper deposits inside the hepatocytes. This is used in order to establish a definitive diagnosis. We do have scoring systems, which take into account various features and lab results to establish a diagnosis of Wilson's. We also have certain investigations. First is to check serum copper, and this is usually low in Wilson's disease. Second, we look for Kayser-Fleischer rings. And third, we do an MRI brain, which can show some non-specific changes that indicate Wilson's disease. How is Wilson's managed? Well, it's obvious we have to remove the excessive copper from the body. Think of the 3 Ds. Number 1, diet. Number 2, drugs. And number 3 is displacement, meaning liver transplant. Diet, we know, eat less food which contain copper. 2 is drugs, penicillamine. This is a chelating agent for copper, to remove copper accumulated in tissues and prevent reaccumulation. The 2 meds you should know are penicillamine and Trientine. Penicillamine, like a penny, we know is copper. It works by binding to free copper in the serum and makes it easier to excrete. Patients can also be given zinc and ammonium tetrathiomolybdate, both which reduce copper reabsorption, and so more copper is excreted in the urine. And lastly, displacement. If we see cirrhosis and liver failure, a liver transplant is probably needed. Alright, good stuff. Here's some high-yield bullets before you go. Number 1, most liver diseases will have elevated ceruloplasmin levels except for Wilson's disease. Number 2, remember Tim's silver stain for liver biopsy. Number 3, there's increased copper in the blood because the liver cells are fed up with the copper and are passing it along to the rest of the body. Number 4, high copper levels on liver biopsy can also be found in primary biliary cirrhosis and primary sclerosing cholangitis, PSC. Number 5, Kayser-Fleischer rings, which are found in the cornea of the eye, but they are not always Wilson's. They can also be found in primary biliary cirrhosis. And finally 6, any adult less than 40 years old with a chronic liver disease should be screened for Wilson's disease by serum ceruloplasmin, screened for copper in urine and blood, and using the slit lamp exam. And that's it. Don't forget to watch our lesson on hemochromatosis. It's a great review. Let's send you off with a quick question. Which is not a feature of Wilson's disease? A. Dystonia, B. Hemolytic anemia, C. Testicular atrophy, or D. Chronic hepatitis? Drop your answer in the comments below. If you'd like to see more of this lesson, head over to our Instagram page and TikTok channel at rev.med. We'll have this lesson along with many other topics for you to study. By the way, don't forget to do questions. Are you learning something from our videos? Well then click the subscribe button to your right. We are releasing high-yield lessons and ways for you to get ahead in class. Be sure to follow us on Instagram to take interactive quizzes and view your favorite diagrams. Nothing can stop you, but only if you believe in yourself. You got this.